Okay, welcome to part 3, and this will be the third and final part of this talk. Now, we left off last time talking about adrenal cortical carcinoma, and I want to show you some examples. Non-contrast, it could be a large adenoma. It's smooth, well-defined. On the vascular phase, it's more irregular in terms of enhancement. You'd worry about a MET, you'd worry about a primary ACC, even in theory a Pheo, but this is going to be a malignant lesion. And here it is again on the 3D mapping. This was an ACC. Here's another example. The lesion is irregular. There is some coarse calcification. The lesion is somewhat vascular, and it's hard to separate from the liver, and it comes really close to the IVC. Again, you could go through a differential diagnosis. One thing with adrenal cortical carcinomas, often the shape is irregular. You know, you think about Pheos, to me, they're more round or oval. ACC often can be like this. Dystrophic calcification can be in a number of things, but ACC is a good possibility, and this was an ACC. Here's a larger lesion. Now here it's easy, right? Large lesion, lots of vascularity, lots of necrosis, dystrophic calcification. Okay, it's hard to get past anything else here. There are these rare sarcomas of the adrenal. I guess you could throw those in if you wanted to be desperate. You see one of those every couple of years. But this is your aggressive ACC. There's vascular involvement. There's local spread. Patients will do poorly. You can see on the cinematic the really extensive necrosis of the tumor. Another one on the left side. Not very vascular, but there's some vascularity. It's large. You can see some necrosis, but again, the size is what drives me. Now, could this be something else? Well, if the patient had hepatoma, I could think about metastatic hepatoma or even melanoma. Both of them give large, relatively hypovascular metastasis at times. Here's another one, hypervascular lesion, right adrenal gland. Calcification, somewhat necrotic, lots of areas of neovascularity present. You might think about a Pheo, but Pheos typically are more homogeneous, but not necessarily so. But here it is again, that typical appearance of a mass of the adrenal, but this marked vascularity. You're kind of stuck with an ACC till proven otherwise. And again, the washout values really do enhance, in this case, the central tumor and necrosis. Now, what about this case? Now, this is a 17 millimeter adrenal lesion. If I read this, I would say adenoma. And this is the reason you get functional imaging, right? This patient had hypertension, so you were concerned when you saw the lesion that yes, it's small, but it's probably an aldosteronoma, which is typically a benign lesion, all of 17 millimeters. So there's the nodule, and this is going to be the reason the patient has hypertension. So we go in, remove the nodule. It's small. Well, guess what? This ended up being a malignancy. What happened was, in aldosteronomas, there's a small percent that are malignant. But because they were hyperfunctioning, they presented early. This was one of the smallest ACCs I've ever seen. The margins were clean, and this patient will be treated conservatively. A really nice example of the importance of correlation of the clinical findings with the imaging findings. Now, we talk about primary adrenal lymphoma. Most of the time we talk about lymphoma involving the adrenals. It's secondary involvement. It's a patient who has liver, maybe kidney involvement, lots of adenopathy. Primary adrenal lymphoma is more common in elderly men, more common bilateral, and patients may present with symptoms of adrenal insufficiency. What's unusual about these masses, they're very large. They kind of maintain the adrenal oval shape, but are really large. They often exceed 10 centimeters in size. They're almost always going to be bilateral, but not always. And again, what could be confused? Metastasis can be confused. Probably not Pheos and probably not a primary ACC because they're so large and bilateral. Adrenal lymphomas tend to grow in an infiltrative manner, maintaining the adreniform appearance. However, it may progress and have heterogeneous enhancement with necrotic or cystic components. And when they do have that, it becomes more of a challenge. Here's a nice example of lymphoma. Big left adrenal mass. You could think about ACC, metastasis. There's also a mass in the pancreas. There's a little dilated pancreatic duct. Could this be two different tumors, pancreas and adrenal? But, there's no intrahepatic duct dilatation. Doesn't look like your primary tumor of the pancreas, like a adenocarcinoma. Got to think different. You got to think lymphoma. So you have pancreas and adrenal soft tissue density. Think about lymphoma. What about this case? Bilateral adrenal masses that are large. They have that adrenal shape. They both enhance, but they're not very vascular, low density. This is classic for primary, not adrenal cortical carcinoma, but lymphoma. Could this be an adrenal cortical carcinoma, you might ask? Well, 5% of ACCs are bilateral, but when they're bilateral, usually one is large, like 8-10 centimeters, and the other might be 2 centimeters in size. This is primary lymphoma. Here it is very nicely with the infiltrating nature of the lesion on the cinematic rendering, well shown in this case. Another example, primary B-cell lymphoma. Again, bilateral adrenal masses, some enhancement, though relatively low density, infiltrative, pushing on the kidneys, and again, very nicely shown, slightly different in terms of appearance between right and left on the cinematic rendering. We wrote an article about this and made the point about primary adrenal lymphoma. The adreniform shape is typically maintained. Now, one of the reasons it's important to be able to suggest lymphoma, we mentioned that we never do biopsies, right? Because if you have a biopsy of an ACC, it can seed the tumor. And you don't want to do that. You want to do an open procedure. But if you're sure it's lymphoma, you don't want to do an open adrenalectomy for lymphoma. So you want to biopsy it to prove it's lymphoma, then you treat with chemotherapy. So you better be certain when you think it's lymphoma that it indeed is lymphoma. And you can see with bilateral adrenal masses, Pheo's rates the top of the tumors. Lymphoma is number 3 on the list. And again, most things can be bilateral, but fairly infrequently. Now, another thing to talk about a pheochromocytomas. Pheos, 90% are in the adrenals, 10% are outside. Is that rule of 10? 10% are malignant, 10% are bilateral, 10% of the time you might miss the lesion if you don't do the study correctly. When we talk about the extra-adrenal pheochromocytomas, we talk about organ of Zerkocondyle, but also talk about the bladder. Pheos are part of syndromes. 90% are sporadic, but 10%, again, the rule of 10, von Hippel-Lindau, MEN type 2, neurofibromatosis, and paragangliomas syndromes. Now, we always like to think that Pheos present with symptoms of hypertension, which is why when all the initial work of coming up with adrenal density to determine benign lesions was done, they always exclude Pheos because they said, oh, everyone knows what a Pheo is because of clinical presentation. And this study was from Hopkins. 70% of new cases of surgically proven Pheos were detected by serendipity. So only 30% were classic hypertension, 70% incidental. So a word of warning and good advice, perhaps. Perform biochemical evaluation for adrenal masses under 4 cm with cystic and or necrotic change and hyperenhancement, even if the absolute washout is above 60%. One of the things we know with pheochromocytomas is their washout is really high. You can see a pheo go from 20 non-contrast to 200, and then it washes out to 70, and you say, oh, and washed out more than 60%, it's a benign lesion. If a lesion enhances above 120 on venous phase, to me it's a pheo till proven otherwise, and I don't care what the washout value is. I'm not going to assume it's an adenoma. Again, lab tests will make your diagnosis for you. In this article, we wrote about the pheos, the uncommon appearances. We talked about oval, hypervascular enhancing lesions. We talked about if the venous level exceeds 130, and I still would carry it down to 120. It's more likely a pheo. It's rare to see adenomas above 110. I don't trust them above 120. So again, you want to be very careful in terms of not using a washout when you have very high values. And again, the importance of pheos. Pheos in the syndromic cases are often smaller. They're often also going to be bilateral. So you got to be very careful. When you look at them, there could be lesions in the 1 centimeter range, somewhat vascular and bilateral in configuration. Pheos can have calcifications, prominent vascularity we've mentioned, and again, the washout value is intense but not important. And again, we can't typically tell whether a pheo is benign or malignant. Obviously, if it's invading vessels or it has liver mets or lung mets, it's easy to call it malignant. Otherwise, it's truly impossible. Some examples. Here's a mass in the right adrenal. It could be almost anything. There it is, early phase imaging. Look at the vascularity of those right adrenal lesion. Look at the impressive appearance on the coronal and on the MIP imaging. To me, this could be metastatic renal cell carcinoma, but the kidney is fine, so that's not the answer. It could be melanoma occasionally, but usually not this vascular. Pheos is where you need to put your money. Yes, you could think about an ACC, but again, typically not that vascular. And this is going to be a pheochromocytoma. And look how it washes out. If you measured the washout value in this patient, the washout value was 70%. If you also looked on later phase imaging at this lesion only, because you were looking at, let's say, the kidney or the abdomen, you would never have suggested a pheochromocytoma based on the appearance. Here's another example, a small lesion, right adrenal gland. Again, measures an average of around 26 Hounsfield units. Could be benign. You want to do a washout. But when you do the washout, look at the early phase. It enhanced to over 260 Hounsfield units. Again, this is a pheochromocytoma. Look how bright the lesion is. Again, differential you consider, but there's no renal cell here. This is not going to be an ACC. This is a pheochromocytoma. And again, look how quickly and vigorously the lesion washes out. Pheos can be cystic, so not every pheo has that really easy to diagnose, very vascular appearance. Pheos can be cystic with some peripheral vascularity, but they can be cystic and necrotic, so it can be somewhat challenging. These are the ones that look more, or at least make you think about an ACC as a possibility. As pheos enlarge, the masses tend to undergo ischemia and necrosis, which accounts for central degeneration and fibrosis, reflected as heterogeneous enhancement on CT. So again, cystic pheos occur, and every once in a while you get a dense hyper-enhancing rim on a cystic pheo called the ring sign, and that's a good sign for a atypical but a pheochromocytoma. Here's an example, large mass, right adrenal, necrotic, vascular. To me, I'm thinking adrenal cortical carcinoma. This is an aggressive, looks malignant to me. The patient also had liver lesions. This was an ACC, all things considered to me, but on biopsy, or rather resection, this was a pheochromocytoma. Now, adrenal masses with cystic or necrotic change, obviously cysts, metastasis, particularly from things like melanoma, pheochromocytoma, as I showed you, and adrenal cortical carcinoma, as I showed you as well. What about this case? Almost an 11 centimeter right adrenal mass. There's some cystic changes and solid components. There it is with venous phase imaging. Lots of cystic changes, really necrotic. This was also a pheochromocytoma. Now we can see extra-adrenal paragangliomas or pheochromocytomas, common locations, carotid body, organ of Zerkocandel, and you want to make certain you look through the pelvis because they can occur in the bladder. Here's a classic one where the patient's adrenals look great, but we were concerned about pheo, and when you scan downward, here's the paraganglioma at the level of the organ of Zerkocandel or the aortic bifurcation. Here's another example. A patient was hypertensive, rule out dissection. The adrenals look great, the aorta look great, but there's a mass in the bladder. Now, normally you would say this is a bladder cancer, but in a hypertensive patient with no cause for the hypertension, you got to think that's going to be a paraganglioma in the patient's bladder, and it indeed was. Now, something else, of course, to consider is metastasis. There's a range of appearances. Usually the tumor is known. The patient has a known primary. Typical sources are lung cancer, renal cell, melanoma, hepatoma, colon cancer. We know that renal cell will give typically vascular metastasis. Melanoma and hepatoma give the largest metastasis. And again, it's somewhat challenging how we manage adrenal lesions. Now, I mentioned we don't like to do biopsy. If a patient has lung cancer, for example, and the patient's unresectable, and the therapy to be done is determined whether or not the patient has Mets, and you have an adrenal lesion, we'll then biopsy that lesion. But otherwise, we will not. Some examples: hepatoma, right lobe of liver, and a really large left adrenal metastasis. Again, if you ignore the liver, you could say maybe this is a primary ACC. Here it is again with the cystic and necrotic and some areas of nodularity and enhancement. Here's melanoma. Bilateral adrenal masses, melanoma, hepatoma, renal cell, all commonly do that. You can see some stranding around the masses. They're solid but somewhat necrotic. Now, looking at the future, we need to have better understanding and perhaps better guidelines, but also perhaps we can do better in terms of analyzing lesions. There's work going on with machine learning now to see if AI can be useful. In this one article with radiomics, CT-based radiomics outperformed MR, aligning with guidelines favoring CT for assessment. But also, when you start looking at this whole area of AI and radiomics, the possibility of looking at the complicated lesions, the ones where we're not certain of, perhaps AI can be valuable in analyzing. And we talk about radiomics working with pancreas, working with liver, working with breast. Perhaps it can also work with the adrenal, and that would indeed be very helpful. So I think a good conclusion: adrenal protocol CT is a modality of choice for evaluating adrenal masses, as it can characterize a nodule using both density measurements and contrast washout. An adrenal protocol CT consists of a non-contrast scan, followed by imaging at 60 seconds and at 15 minutes. Again, some of the pitfalls with washout I've told you about. Don't do 10 minutes for the washout. If the lesion enhances really bright above 130, we don't care about the washout. It's going to be a pheo and not a rapidly washing out adenoma. So again, learn the rules. And again, we're learning how we can do better. We're learning how much of the adrenal evaluation needs to involve endocrinology and endocrine functions. And that's something I think with AI that we'll learn more about. And with that, have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.